Assalamu alaikum warahmatullah. Today we try to cover a very beautiful, important, some of my favorite topics, nephrotic syndrome in pediatric. It's not only a pediatric case, but it's very common in children. One type, which is minimal change disease, we call it. We'll explain about it later. So, starting from nephrotic syndrome. What's actually nephrotic syndrome is when the patient present with proteinuria, and proteinuria will be more than 3.5 gram, okay, in urine. So this is what we call a patient with nephrotic syndrome. He's losing protein. This is just simply. So how does he lose protein? And what's the criteria to define this nephrotic syndrome? Let's first know the pathophysiology, because it will be easier for us to know the criteria. So first, the pathophysiology is simply when we have like damage to Bowman's capsule, this area we call it Bowman's capsule, right? Revise your physiology. So if there's any damage because of autoimmune disease, inflammation, any injury, the lining of this area is the podocyte, right? This area is the podocyte, and the podocyte is like actually food processes that like doesn't allow protein to come. So this is normally supposed to be like this. This is how is it? It's closed. The podocyte, they don't allow the protein, like the permeability is very small, and the protein is like, let's say, bigger in micrometer. So, but if there's damage to this podocyte, they will start increase this permeability, and the protein can pass from the capillary. This is afferent or afferent capillary. So the protein will pass out to the Bowman's capsule, damage, and then goes into the urine. So increased permeability of glomerular basement membrane, and this will cause the protein loss. So I told you 3.5 gram, but it's in 24 hours, like not 3.5 grams over the week. You actually lose more than that normally. Okay, this will cause what we call proteinuria, and may be associated with hematuria or may not, but so typically it's not, because hematuria is more with nephrotic syndrome, NFRI. And because of you are losing protein, what is proteins actually? There's so many proteins is your coagulation factors are proteins, your immunoglobulins are proteins, right? So what else are proteins? Any protein that can be lost in urine. So you'll try losing immunoglobulin, and immunoglobulin is your immune system. You're losing your immune system, so you'll be high risk of infection because of this. And because of losing albumin is a protein, right? You'll be having hypoalbuminemia. So this is one of the criteria: hypoalbuminemia and proteinuria. These are one of the criterias. And then because of hypoalbuminemia, your liver will try to compensate, right? Like this is your liver, okay? And the liver will try to compensate. How does she compensate? By making more proteins, breaking down synthesis of amino acid, and actually because of this process, also the liver, it's not the doesn't differentiate, but with the protein she makes also cholesterol, right? Because of this we have another differential for the criteria, what we call hypercholesterolemia. So it's making protein synthesis and cholesterol, and because of this in your capillaries they will be reduced in the oncotic pressure. You're losing protein, right? So reduce in the oncotic pressure in your capillaries, which allow the water and electrolyte to move to interstitial space. So this is your capillary, okay? It's normally like this. This is the normal, the down one. But because of the decreased oncotic pressure, sorry. So this is your capillary normally, okay? But because of the pressure, normally, the differences of the pressure, here the protein does not move, but when the oncotic pressure is different from this area to this area, it will reduce, so the protein will start to leak out. This is a more important pathophysiology in so many diseases. So water and electrolyte move to interstitial space, causing edema, and this is one of the also criteria. And then our body, to compensate this, also no sorry how does this is one theory for edema. There's another theory where like now your heart is receiving low volume, right? Not low volume, but low blood, low, what do we say here, low albumin, low plasma and oncotic pressure, fluid moves to interstitial space, reduce volume circulation. Yes, this is the part, reduce volume circulation. This is actually same as this one, but because of this one we'll be having also reduce in volume in circulation. Your blood, your venous return is reduced, right? Your venous return is also reduced, so your heart will work less harder, and then bump less volume. And because of this, you know, always the hypoperfusion, what's the first organ is affected is the kidney, because the renal arteries, like this is the kidneys, the renal arteries are not receiving enough blood, reduce renal blood flow. Because of this, we have low glomerular filtration rate, and also the body try to compensate. What will happen? He will activate the renin, angiotensin, aldosterone system. Why does he activate it? Because now we have low blood pressure, right? And the body feel that the kidneys is just having low blood pressure. He doesn't know that there is low volume in our body. He's just asking for more blood. So he will increase the RAS system to increase the blood pressure, renin, angiotensin, aldosterone, to increase the blood pressure. You get it? And then to compensate, then we'll be have high blood pressure instead. And also what RAS do, compensate for low blood pressure. It retain, how does it increase the blood pressure? Retains water and sodium. So return water and sodium. It's actually return sodium, but water always follows sodium, will end up with edema. A small note that the glomerular basement membrane have negative charge. This place has negative charge, but when there's a damage, it will lose its negativity. So because of this, it will be less negative, and the protein is negative charge. So if this is losing its negativity, let's say it's becoming positive, it's not becoming positive, but it's losing its negativity, so it will attract the negative charge to positive charge, and you will lose even more protein. This is the pathophysiology. Now you understand what's the criteria. You understand it. You don't have to memorize it. You can remember. Edema. I'm not looking. Edema. We're losing protein. What do we have? Hypoalbuminemia. Ignore my spelling. 3, hypoalbuminemia. Losing protein. We're losing. How do we compensate? We're making more cholesterol, hypercholesterolemia. And the fifth one, of course the most important one that causes all these four, the proteinuria. And don't tell me there's just a proteinuria. You have to tell me, so let's fix it here, more than 3.5 gram per day in 24 hours. And the hypercholesterolemia, it has to be more than 200. Actually normally it's around less than 170 in children. Hypoalbuminemia, it has also to be more than less than 25 gram per liter. Okay, this is the criteria. Pathophysiology is done. Moving on to what did we look? Okay, so I'm missing some points, just came to my mind, that maybe sign and symptoms. And 2, also I wanted to cover there's another theory for losing coagulation. What does happen because of losing coagulation factor? I will add them later, okay? Stay tuned. Coagulation cascade. Okay, so moving on to the pathology, more pathological. What is the type? We have three main types. I think you have to know only these two, because the third one in pediatric is not important and it's rarely seen in children. So whenever you're suspecting nephrotic syndrome, you will always think of, yes, minimal change disease. It is the most common one. It's up to 90%. Okay. And the second one is focal segmental glomerulonephritis. So what's minimal change disease and focal segmental? We call it minimal change disease because it's also known as nil disease. Okay. When we do microscopy is different than when we do light microscopy. So normal light microscopy, when we do it, what do we see? We see nothing, actually nothing. It just looks normal. Okay, that's why. And then but if we do electron microscopy, what we're gonna say? We're gonna say that the podocyte I've told you about, they are injured, that we call it effacement. Show diffuse effacement of the food processes. So that's why we call it nil disease, and it's steroid sensitive. We don't do any biopsy here. Okay, you have to keep in mind, we just treat with steroids. Once he responds to steroid, we confirm the diagnosis, but we don't do biopsy. The second one is very less, like rare also, up to 9%, let's say, and 1% for that last one. Focal segmental, the last one called membranous nephropathy, and it's more common in adults. Focal segmental glomerulonephritis, also more common in adults. It's same as minimal change disease, but the extra thing is we have sclerosis. It's also on electron microscopy. We see diffuse effacement food, and light microscopy we see nothing, but we see effacement with segmental sclerosis. And it's more in adolescent, like in who's close to be an adult, children. Okay, what is okay, let me tell you something. There's 4 typical features of minimal change disease. There's no persistent hypertension. Okay, the patient presents not his hypertension, not persistent. Yes, no gross hematuria. Maybe you can find microscopic hematuria, but patient doesn't explain of hematuria, and he responds well to steroids. And no renal impairment, so it's not benign, but it's curable. Okay, so what are the 4 typical features? They are important to remember. Idiopathic nephrotic syndrome. Okay, no persistent hypertension, no renal impairment, no gross hematuria, and response well to steroids. Okay, what we're talking here about, it's a bit messy. Complication and then supportive treatment. Management. Okay, before we cover management, complication. If you did not treat nephrotic syndrome, what will happen? Infection, because we're losing immunoglobulin. Thrombosis, because we're losing coagulation factors. Poor growth, because of the low volume. You see, when you understand the physiology, you even can tell your own complication. Not your own, but makes sense. Renal insufficiency, because of what? Reduced renal blood flow. Hypovolemia, of course, we say reduce volume, reduce venous return, and side effect of the steroids. Sadly, for the patient for lifelong steroids will be having this side effect. Sorry, 1 minute. Okay, how do we manage? So the first line of management, you want to say, let's cover the supportive management first. Or no, the main management is steroids. Of course, steroids, because it's immune system affecting our probably our kidney inflammation. Like this, it's either inflammation, immune system, so we always use steroids. And yes, what do we use? Prednisolone, and always it's the initial episode we use only 60 milligram. It's what do we say, it's all over the world, this thing. For 4 weeks you use it. So first you use prednisolone 60 milligram per meter square per hour for four weeks. Okay, you don't have to remember more details. And then this is the initial episode. Then the second episode, prednisolone. Okay, you use prednisolone, but you reduce the dose for 40, right, 40 milligram. And then it's alternate. So one day you give, one day you don't, one day you give, one day you don't. Why? Because you're trying to reduce the dose, and you're trying to give the same effectiveness of the medication, but without getting the side effect of the steroids. If you take away the steroids, suddenly he'll be having like Addison's disease and this very severe side effect that we don't want, right? So, but first, I forgot to tell you, if he respond well to this treatment, you so very important, you look to his urine back to normal. So if there's a response, you complete on this. If there's no response, you should proceed with biopsy. And after it's alternate, you do this for 4 weeks. Okay, day 4 weeks, and then after you covered 4 weeks, 4 weeks, so you covered 8 weeks so far. So then taper over the 4 weeks and stop. You gradually reduce the dose. Okay, after this 8 weeks, this is how I understand it. And then the management, supportive management. The child will be having normal diet, but if there's like you can ask him for salt and ask the parents for salt restriction if he has like severe edema. And then penicillin we only give as a prophylaxis if there's infection, if we're suspecting infection or that the trigger the nephrotic syndrome. Assess the hemodynamic states because the patient may be hypovolemic or hypervolemic, right? So if it's hypovolemia, you're looking for low capillary fill time, cold peripheries. If he's hypervolemic, so he's retaining more fluid, crepitation, bronchi, hypertension. For fluid restriction, diuretics, albumin, only these if needed. So you don't give them, depend on the case, exactly. I want you to note about vaccines. It's important note actually about vaccines. For nephrotic syndrome, they're losing albumin, so they're suspecting low immune system. So it's safe for child while he's on steroid, the killed vaccine. But the live attenuated vaccine is only you give it for like after 3 weeks to 3 months of treatment. Okay? The killed vaccine, like what? PCG, right? Yes. Okay. You have to know also the side effect of this prednisolone. We covered everything here, right? Moving on. Side effect, the most important one in children is poor growth retardation. And then iatrogenic Cushing syndrome. It's if it's not like managing well, if you give more than milligram, 100 milligram, that's why we go for 60. And then immune suppression, flaring infection, recurrent infection, because the main thing is anti-inflammatory, it's immune suppression. You cannot like ask me for side effect of steroids. I'm not saying this. Hypertension due to salt and water retention. That's why you sometimes give diuretic if there's like edema. And hyperglycemia, because remember they are glucocorticoid are increased. Revive physiology for this. Osteoporosis, tetragenic effect for a mom's, like cleft palate, skin atrophy, and hypopigmentation. Hypopigmentation when you give someone to steroids. Maybe patient present with a child present with CAH, which is congenital adrenal hypoplasia, and his symptoms show hyperpigmentation. Okay, when he presents with hyperpigmentation for CAH, it's how do we say we give steroids, so he have hyperpigmentation, something like this, but his ACH is very high or cortisol hormone is very high. And patient might have depression or euphoria, it's like fluctuate. And we are scared of glaucoma because of increased intraorbital pressure. Okay. Some notes that my prof told me. Remember that acute glomerulonephritis. Acute glomerulonephritis, post-streptococcal infection, never present with ascites, okay? So that's why how you differentiate it from nephrotic syndrome patient. If you saw ascites, you always rule out AGN, okay? And how do you calculate the surface area? The M2 we here measure always the M2. How do you calculate this by milligram per M2? How do you say the M2 per hour? You have the milligram, you have the hour, and but the M2. How do you calculate it? Is height times height. I don't know is this in English. جذر التربيع you say it, and then over 600. It's very easy. Okay, just remember this not physics. And why you sometimes you see the urine bottle, it's brown in color for yes, the sample. Why it's brown? Because we are scared of the sunlight. The sunlight affect the protein, so we make it brown. So it's reflect, not reflect, it's actually absorb the light, but it's keep it away from the bottle. And then why proteinuria in children is calculated by hour, like in adults we calculate it by days or 24 hours, because it's very hard. The children, they pee everywhere. They pee in the diapers. They might pee on the bed. They might be crying. They never answer for you to have a correct measurement though, so it's easier for per hour. And that's it for today. I'll be looking for these two and send them. Of course, signs here present with foamy urine and these things, but I want to cover it probably, make sure I won't miss everything. Thank you for listening.